Okay, I think we're just about there, and let's get started. I want to welcome everybody. I'm Dr. Bob Harrison. I'm with the University of California, San Francisco and the California Department of Public Health. I'm very pleased that our partnership between the Council of State and Territorial Epidemiologists, the Western States Occupational Network, a regional meeting of CSTE, the American Public Health Association, and the University of Colorado School of Public Health has been able to join together and present what I think is a really timely and relevant topic on health equity and the COVID-19 pandemic. The Western State Occupational Network meeting would be meeting in person in Denver, Colorado today and tomorrow, but because of the COVID-19 pandemic, has become virtual with this webinar presented today as our substitute. We are rescheduling the WestON meeting for April 29th and 30th in Denver, Colorado, and at this point, depending on where we are with the COVID-19 pandemic, will take place face-to-face, but if not, will become another in a series of virtual meetings that many of us have gotten very used to. A few housekeeping details. I'm going to present the speakers. They'll go to follow each other. We'll hold questions to the end, and I ask if you would put your questions in the chat box. So not the Q&A box on Zoom, but use the chat function. I'm going to be moderating the chat questions, collecting them, aggregating them, and then asking our panel members at the end, and I hope we have plenty of time for the Q&A to our panel members at the end of the webinar. The webinar will be recorded and will be posted on the YouTube channel at the University of Colorado School of Public Health. Everyone will get an email who registered in about 2 days, and you'll have a link to the recording, including the slides. When you leave the meeting today, you'll be linked to an evaluation, a very brief online form. So if you would just take a minute or so to complete so we can get some really good feedback on how the webinar went today, that would be great. You'll also get another link to remind you if you haven't when you get the recording URL in a couple of days. I just want to end before introducing our speakers with thanks to CSTE, APHA, the National Institute for Occupational Safety and Health, particularly the Western States Division, which has been an integral partner in our WestON meeting for now going on 13 years, and our academic partners and institutions who've all really been keeping this meeting going. So we have 3 terrific speakers today to talk about what I think many of us in the public health and academic and worker advocacy communities have been so focused on since February of this year. COVID, as I think we'll hear from Dr. Benjamin, has had a tremendously disproportionate impact, particularly on communities of color, on a community and population level. And that's for a number of factors, which I think we'll hear about from Dr. Benjamin. One of those factors has surely been the fact that these communities have been what we have deemed essential workers who've needed to go to work for economic reasons in frontline occupations like meatpacking, long-term care, nursing homes, emergency response, healthcare, now teachers in schools, and many other occupations who face a risk of work-related COVID infection, and also the interplay between that infection and bringing it back home to their families and communities. So we want to highlight those issues in today's webinar. Dr. Benjamin is the longtime executive director of the American Public Health Association, and I'm just really thrilled that he's able to present on this topic here today. So, Dr. Benjamin, turn it over to you.
Thank you very, very much, Bob. Let me share my screen. There we go. Okay, can everyone see that? Very good. Well, let me thank you very much for allowing me to spend a little time with you today. I was going to talk about this pandemic. Just to remind folks, this is kind of my agenda, to talk about the status of the pandemic, why we have these disparities, what a little bit about the strategies that we're using from the prevention side, therapeutics and vaccines, and then talk about safe reopening, just to give it kind of the basics of the outbreak. Obviously, we have over 6.9 million cases of COVID right now in our country, and over 200,000 deaths. That's clearly a pandemic. This has been a significant event if you consider the fact that we're just really in about 8.5 months of this pandemic here in the United States. I always like to talk about this being 3 epidemics. Number 1, the pandemic, the infectious disease outbreak that we're seeing, a tremendous degree of misinformation and disinformation from a variety of reasons. This tremendous epidemic of fear that we have. People are very much on edge, fear of the unknown. Partly, we're in a rapidly moving communications environment, so a lot of the things that we knew today may be a little different tomorrow. There's clearly been poor risk communication at a variety of levels, even from the very top on down. Fear of persecution that's been driving people underground. A lot of the concerns with immigrant communities, which for the purposes of the audience today is a big issue. And the lack of a unified national voice with loss of trust has been a major problem in the outbreak. Just remind you, this is part of the family of coronaviruses that include not only the common cold, but some more severe diseases like MERS, which you get from camel, and SARS-1, which was a SARS outbreak that we had several years ago. And of course, many of the assumptions we made early on in this outbreak were based on the collection of understandings that we had on coronavirus. And quite frankly, a lot of that turned out not to be correct. You know, in general, the epidemiology is that each person can infect 2 other people. You know, Rho has been fluctuating from, you know, around the country and around the world, depending on where you are and what stage you are in the epidemic. But for practical purposes, 2 other people is a pretty good number, except when you have, of course, those super spreaders that are out there. I like to tell people that it's certainly more infectious than influenza, less infectious than measles. We know that early on, it was clear that if you got infected, 80% of the people tended to have mild symptoms, and as many as 20% had severe symptoms. And again, depending on where you are, the case fatality rate's 1.5 to 3.5. It is falling as we know more about the baseline, the number of people that have been infected. This is a complex disease that not just infects the lungs and impacts lung function, but it affects a whole range of other bodily systems, both directly and indirectly through its mode of action. And there's profound community transmission that's occurring, as much as 40%, even in an asymptomatic state. As Bob mentioned, it has been a disparate impact on communities of color. The worst, of course, has been Native Americans, followed by African Americans, and then Latinos, Asian and Pacific Islanders, as compared to non-Hispanic whites. And I'm going to talk a little bit about why we think that is the case. So really 3 big buckets here in terms of the reason for these disparities. Number 1, exposure. The good news is that for a person like me, I get to telework from home. I have little public facing these days. I'm not traveling at all. But if you work in a meatpacking plant or a field as a farm worker, in a poultry farm, if you're a grocery store clerk, if you're a bus driver, if you're a sanitarian, a nursing home operator, a nurse who's working in the hospital, or any of our healthcare providers providing direct patient care, you're at a higher risk. We also had delayed sheltering in place, partly due to confusion, partly due to misinformation, I'm going to talk about that misinformation in a moment. But we also had a nation that saw this outbreak hit them at various stages of the outbreak. So while we had a raging outbreak in New York and New Jersey and parts of the West Coast, the middle of the country was relatively unimpacted. So people didn't believe what they were seeing in TV in other parts of the nation, coupled with lots of political interference and poor political messaging. But that delayed sheltering in place, and as many of you know, continues to delay sheltering in place. Susceptibility, the prevalence of chronic diseases. I mentioned this 80% of the folks that don't get as sick as others, but that 20% tended to be people with chronic heart disease, lung disease, kidney disease, people that were on cancer chemotherapy, anyone who had significant chronic diseases were certainly impacted. And interestingly enough, even people as their only chronic disease having hypertension. And then, like anything else in our society, the social determinants play a huge role in people's ability to get access to care and testing and a whole range of services needed. Big ones, lack of paid sick leave, poverty, a housing situation where they had multi-generational families living in a home or multiple families living in a home. And particularly the size of your home made a difference. So if you have a 3 or 4 bedroom home and you can separate yourself from others should you be exposed or come down with the disease, that's a very different situation than if you live in a 1 bedroom or 2 bedroom apartment with several other people. And then how it's transmitted. You know, this again is not news to obviously this audience. Certainly droplets spread primarily through the airborne route and aerosolization, which I'm going to come back to in a second. Then of course fomite transmission. What's interesting is we spent a lot of time worrying about fomite transmission. We're not seeing a lot of that, at least directly related to this. You certainly, like anything else, if you contaminate your hand and touch the doorknob and I come behind you and touch the doorknob, I can get infected. Or if I'm out in the restaurant and the table is contaminated. It turns out this is a virus that is pretty easily killed through most common chemicals that we use to clean surfaces. Anything pretty much that you can disinfect the surface with. Plus we're in our homes, we're not out and about. And so fomite transmission, we're not seeing a lot of, possibly due to the fact that we're not out and about, and also because it just dies pretty easily on surfaces in most cases. The real debate has been between whether droplet spread or aerosolization is the major cause. I think most people's experience is that this behaves more like a droplet spread, although let me tell you, aerosolization absolutely does occur. And there are many, many case reports of people being downwind in restaurants and other places that have become infected from a single source. We know that prevention for this is the key. The tools we have today are non-pharmacological interventions. That's wearing a mask, that's washing your hands, that's physical distancing, and selective closure of large events. The idea, of course, is to reduce the number of people that are in any one place should someone come into the area with active infection. I think all of you have seen this picture before. Clearly, cause to sneeze is travel. The magic distance is 6 feet because that is pretty much where most of us, when we cough or sneeze, the most variety of the particles that we put out of our mouths or our nose travel, but certainly it can travel further. Lots of good science that shows that it travels further. And you'll notice also the different size in the particles, everything from really small droplets to really, really fine particles. The mask is important. Obviously, the gold standard is the N95 mask. The nation has never really had enough of those, and we're still struggling to get enough N95 masks for those individuals at highest risk from an occupational health perspective need to use that. But it turns out that the surgical mask, aerosolization aside, is an effective cover. And it turns out a cloth mask is an effective cover. And early on, we've all followed the early dictum that don't wear a mask if you don't really need it. It just turns out that the science and the practice experience has shown very, very clearly that masks can reduce up to 80% of the exposure. And if you think about it, if both people are wearing the masks, you're much more protected than if no one's wearing a mask or if one of you is wearing a mask. I do need to talk about stigma. This whole issue of masking while Black, the fact that people in our community, particularly African Americans, also Latinx, are often stigmatized to a great degree. Frankly, anybody can be, including our Asian American, Pacific Islander colleagues. But this is the real challenge. We have actually had situations since this pandemic has started where we've had people who are of color escorted out of stores because they go in wearing a mask, and they've been essentially stigmatized and targeted as being dangerous and threatening, and so that's why they were asked to leave. We also have the anti-mask resistance, again, because this tragically has been politicized. The mask is a public health measure and absolutely should not be politicized. As I mentioned, it does protect both parties. That's a very important part of this, this argument in any environment, and that's particularly important in the workplace. Mask work. Several health officers have now done this comparison in their jurisdiction. This is a great graph by the Kansas health officers that shows that once they began implementing a mask requirement or a mask recommendation, but in this case it was a requirement, they saw a huge drop in the daily cases per 100,000 compared to communities that did not wear a mask. We always, hand washing works. The tragedy is people don't often wash their hands, and they don't often do the 20-second hand washing effectively. But again, it is an effective tool, and we need to continue to do that, because even though I mentioned fomite transmission is not a prevalent part of the exposure, it certainly does occur. And of course, in 1918, we had this similar experience. This is an example of the Philadelphia experience where they, versus St. Louis. Philadelphia did not lock down early. In fact, the health officer was resistant to locking down, and they had a huge spike in cases, significant deaths. And in St. Louis had a much better experience because they wore masks, and they also locked down very early. Which is the example of why we always want to talk about flattening the curve. And of course, the flattening the curve was a goal to not only protect the healthcare system and keep it from being overwhelmed, but the goal was really to try to give us the time so we could ramp up our testing and public health contact tracing capacity. And I tell you, this didn't happen. Unfortunately, that is still lagging, both testing and contact tracing. We know that strategy works. This is from Tom Friedman's Box It In strategy, where we talk about testing, isolation, contact tracing, and then quarantining those people who may have been exposed to the disease, and isolating those people in the hospital or other places that have been infected, and then continuing that cycle to try to contain the disease. Increasingly, we're getting better therapeutic interventions. We really were struggling with our understanding of how this disease infected people and impacted people. Anybody who needed a ventilator was sent on a ventilator. It turns out that we can actually manage both the airway and oxygenation a lot more effectively. And so we've learned a lot about pulmonary management in this disease. They've struggled with some early antiviral agents. They do have some on trials going on right now. Remdesivir. Turns out hydroxychloroquine is not an effective one, although of course it was tested very early on. Because this disease creates a great deal of immunological instability, steroids for the right patients at the right time seems to have a modulating effect on the disease. And using antibody-rich plasma from people who've been infected is being used under emergency use authorization right now. So theoretically under some controlled conditions, but frankly not enough under a clinical research protocol. And I think many of us would prefer to use it under the research protocol and not the emergency use authorization, but it's out there. And then this whole issue of monoclonal antibodies is becoming an early activity. We will have a vaccine. I think most of us don't think it'll be available until after the first of the year. And then the question hopefully is safe and effective. There will be some performance variables around that, and this whole issue about affordability around costs, even though the Fed said they're going to give the vaccine for free. That's wonderful, at least initially, but there is a cost to also administering the vaccine. And one of the things we now know is that at least most of the predominant vaccines that are being in phase 3 trials right now have to be deep frozen to temperatures like over 100 degrees Fahrenheit. So the next steps, I think in the vaccine story is trying to figure out who should get it. And right now there's a great push to make sure that be based on risk. And risk may include where you work. And then production, the feds have jumped a lot of money into this so that companies are now producing it, additional doses in addition to the ones they're producing for their studies, so that we'll have a reservoir of some vaccine available. Of course, if one of these vaccines turns out not to work, that's some money down the drain, but folks think that that's worth it. We have to, again, put in place a very robust distribution system with all the caveats I talked about around temperature. And then obviously vaccine hesitancy and acceptance is a big deal. And then the delivery. At least 3 of these vaccines require 2 shots. The Johnson & Johnson vaccine that was just announced apparently is only 1 dose. And then of course we have to follow the safety. We've already had 1 vaccine that's had 2 patients with transverse myelitis, which is inflammation of the spinal cord. And then of course managing any other side effects. And then as we think about reopening, the secret to reopening is reduction in the clinical parameters around death and hospitalization, having a health system that can manage it, a public health system that's robust, that can do adequate testing with a positivity of less than 5%, which is ideal. And then the lower you can get, the better. New York is around 1%. Maryland is around 5.5% where I live. And then adequate contact tracing and the ability to effectively isolate and quarantine is going to be an issue for many people. Isolating quarantine, as I mentioned earlier, is difficult for them. So with that, I'll stop as my overview, and I thank you very, very much.
Thank you so much, Dr. Benjamin. That was a terrific overview, synopsis, you, by the way, though, I have to say you have such an effective way of communicating. You're one of the people that I trust. When you say something, I listen. And I think that that's so important right now. Because I would just add that there's a lot of politicization of information. And I think that's one of the things we may loop back to in our chat or question and answer session. So I want to turn this over to Celeste Monforton. Celeste, longtime colleague, is a lecturer in public health at Texas State University. Celeste directs the Beyond OSHA project, which is a collaboration with community labor organizations where workers claim their power and use tactics to improve health and safety on the job. Celeste has also been one of the stalwart and longtime leaders within the American Public Health Association occupational health community. So I thank you very much, Celeste. We're going to move to a discussion of inequity and disparities that have affected our frontline workers. Celeste.
Thanks, Bob. Can you hear me okay?
Yes.
Okay, great, thank you. And as Bob said, I'm going to be sharing what I've learned over the last however many months has been since February through my collaboration with a network of worker centers, which are community labor organizations. And this particular network has members who work in meatpacking and poultry plants. But I do have to say that my colleagues in the occupational health and safety community relay some of the very same experiences among workers in other essential industries. So I'm trying to advance my slides. And let's see, I'm going to stop sharing for a minute. I'm having trouble advancing my slides. Can you still see my screen?
No.
No. Okay.
Celeste, if you go to the bottom left-hand corner, when you go to slide view, hover over the left-hand corner, you should see the slide advance left.
Here. Can you see it now?
Yes.
Okay, great, thank you. So to understand some of the health disparities that we're seeing related to COVID-19, we really have to look at work-related health disparities before COVID-19. And if you look at this photograph, you'll notice below the waist of these demonstrators that they're wearing diapers. This is a demonstration that occurred in Bryan, Texas on the driveway into the Sanderson Farms poultry processing plant. And this group of workers with some allies were demonstrating that workers in the plant do not have access to use the bathroom when nature calls. And this was an issue that was most important to the workers in terms of doing a demonstration of all the different health and safety problems and labor rights issues that they face in the plant. This was the one that the workers decided was most important. And so you can, hopefully you can recognize that the lack of control over something so fundamental for adults to be able to use the restroom when they want to is emblematic of why we are seeing disparities in poultry and meatpacking plants. Just briefly, poultry and meatpacking workers are predominantly immigrants and people of color. If we look at a state, for example, Arkansas, about 79% of the population in Arkansas is white. But in meatpacking and poultry plants, 87% are Latino, Black, or Asian Pacific Islanders. Another work characteristic of meatpacking and poultry plants, and particularly in Arkansas, less than 15% of these workers have paid leave. And nationwide, the annual income for poultry and meatpacking workers is about $30,000 a year. These are not jobs that individuals could do from home during the pandemic. They don't have flexible work schedules. And so it's this mix of factors that lead to the health disparities that we are seeing with respect to COVID-19. And I think that for the benefit of the larger public, certainly something that people in public health have recognized, but for the larger public, it's shedding some light on the important role of work as an important determinant of health. When we think about work-related factors that can enhance health or impede health, these are some of the ones that come to mind. And there's certainly ones that we saw during the pandemic and continue to see as factors that are adversely affecting people's ability to control the virus and to stay safe and healthy. If we just look at something like job control, this is having some say or some power over how your job is done. So as I said, just having the simple ability to use the restroom when you need to, In poultry and meatpacking plants, workers have never had the ability to control speed of the processing line. Even when workers are absent and there are fewer works on the line, the processing speed is the same. And so those workers who are there have to work that much faster. And we hear workers say things like, you know, we aren't robots, and we should have some say in how fast processing lines, the speed of the processing lines. I'll share an example of COVID related to COVID-19 with respect to job control. So we know in March and April, the very important messages that we had from our public health authorities were two things. You know, physical distancing, don't be in, you know, around a lot of other people, and wear a mask. And this is the same message that poultry and meatpacking workers were hearing in their own communities. A poultry worker in North Carolina, at her workplace, the company was not providing any masks. They didn't want to send a message to the public that there was a problem in the plant, that there might be COVID-19 in the plant. Workers started to bring in their own face coverings, and even some workers were making face coverings for others, which was something that was celebrated in communities across the country. And these workers were prohibited from wearing the masks that they brought in to the workplace. And that continued through about May of this year. Another feature of working conditions in these plants is only about a third of poultry processing workers have access to paid leave. And even setting aside the pandemic, no paid leave is an incentive for people to go to work when they're ill. And on top of that, many poultry and meatpacking companies have what workers call a point system, where workers are penalized for being absent. And when you know, the outbreaks in meatpacking and poultry plants started to get public attention, and there was negative press that these policies and practices of penalizing workers for not showing up for work were likely contributing to the outbreak. Some of these poultry meatpacking plants did set aside these punitive policies, but they were set aside temporarily, and in some places they have been reinstituted. One of the messages that I heard so often in conversations with poultry processing plants is similar to what a worker named Alma said, that she was just so afraid of bringing the virus home to her family. And this was very typical in March through June of what I heard from workers. In this particular town and in poultry and meatpacking plants around the country, this is the biggest employer next to the school district. And so the link between what happens in the workplace and what happens in the community is very tightly linked. And workers in mixed status households are very unlikely to speak up about safety concerns. Also heard from workers about secrecy with respect to knowing who in the plant has tested positive for the virus. And I know that this is, you know, a tension with the public health community and confidentiality, patient confidentiality, and all of that. But I want to share with you the workers' perspective. And so, you know, there is this great fear of bringing the virus home to their families, and workers saw the lack of information about who had tested positive in their plant as secrecy. Secrecy, particularly by the company, because they knew that managers in the company knew who had tested positive. So they wondered why they couldn't know. And it wasn't so much they wanted to know the individual worker, but why can't they tell us what shift it was on? Why can't they tell us what department it's in? And for workers who have really come to appreciate understanding hazards in the workplace, they view COVID-19 as a hazard, and that they should have a right to know, if they are exposed to that hazard. The other thing that dominates the conversations that I've had the privilege to hear from workers is this huge contradiction between being called an essential worker, yet companies not implementing what we all have been hearing as the most important steps to control the virus, the physical distancing. They say things like, you say we're essential, the government says we're essential, but there's no mandate for physical distancing. That companies can merely say, we can't do that. It's not possible to do that on the production line. They decide it's not possible without having any input from the workers on ways that it might actually be possible. And so that's when I talk about job control as part of the environment that creates these disparities. That's an example of one example of that. I want to share another example that I put under this category of the work environment as something that can impede health. This is an example of a memorandum, part of a memorandum from a company in Bryan, Texas called Sanderson Farms that was planning to do a screening. This is a memo that was given to the workers on a Friday afternoon. It's notifying them that there would be COVID testing beginning on that Monday. What's really important to recognize is that a very large share of this workforce speaks Spanish and Vietnamese. This memo was only provided in English. Not only is that disrespectful, it's an utter communications failure. In the memo, there was also no information about who would get the results, when the results would be given, will workers be notified directly about the results, that were they going to be notified through their employer, just a lot of lack of information about how this testing is going to take place. And as Dr. Benjamin said, I mean, so much fear in communities because of misinformation. So at the request of the workers, I contacted the county health department, trying to find out a little bit more about this testing. In fact, some of the workers, because this was on company letterhead, they didn't even actually believe that the Texas Department of Health was going to be conducting the testing. Workers wanted to see something from the health department to actually confirm that this wasn't something that the company was doing. It was really clear to me that the county health department seemed to be in a bit of a bind, that they were expected to coordinate very closely with the company. The company was going to be responsible for communicating the workers. The county health department had asked the company to make sure that the information was provided in the languages spoken in the plan, but that didn't occur. And so, it did, like I said, it did seem to be the county was in an awkward position and not really involved in the screening. One of the things that I did learn was that the screening was going to be conducted by soldiers with the Texas National Guard. And this is actually a photograph that one of the workers shared with me from that Monday afternoon. And again, this workforce, there are many mixed status households. Word spread very quickly that in the words of the workers, the military was going to be doing the screenings. And according to workers, about 40 people didn't show up that day for work. And again, to be fair, I'm sharing the perspective that I heard from the workers. I don't know the extent to which the state health department actually had a lot of decision-making authority of how this was going to be conducted. But I think that it really brought to mind for workers in this particular town the raids from 2019 that occurred in Mississippi when about 700 workers were arrested by ICE. So the misinformation, the distrust really can perpetuate what's going on in these plants. I just want to wrap up providing a little bit of data of what we know about workers in frontline industries. So we think of all frontline workers. We can see that there is a unequal or disproportionate share of Black workers in these essential frontline industries, whether it's childcare and warehouse type work, things like your Amazon warehouses, and a little bit more data on looking at essential industries and percentage of this workforce that is non-white. So about 39% of the US population, workforce population is non-white, but we can see in terms of farm workers, 68% are non-white, warehouse workers, and so on. There's been some really great work. I want to give a shout out to the folks in all of the state and local health departments who have been investigating outbreaks and publishing their findings. On the left-hand side is just some data from Nebraska. And again, the population of Hispanics and African Americans in Nebraska is 11% and about 5% respectively, but much more, much higher distribution in meatpacking and poultry plants, and the same similar data for what we're seeing in Utah in this particular case. The last thing I want to share is that there's such a prevalence of messaging with respect to personal behavior, that workers who are in the plants where there have had these outbreaks are basically, let's just be honest, racist messaging about who these workers are. I had a very interesting conversation in terms of some of the poultry companies back in April, very concerned about whether they would be held responsible for outbreaks. And I shared this information with workers from the Worker Center in North Carolina, and this information, that poultry and meatpacking workers, they have big families, they all live together, and so that's where the spread of the disease is. And a poultry industry official said, and what about all those Cinco de Mayo parties that are going to go on? And one worker said to me, Cinco de Mayo is something that white people celebrate, but we don't even celebrate Cinco de Mayo. And another worker said, we're from Guatemala. We don't celebrate Cinco de Mayo. So just, messages like that are not based in reality and are based on stereotypes. I want to finish with just some faces of family members, honoring their loved ones, and also faces of individuals who succumb to COVID-19 in poultry and meatpacking plants. And with that, I'm going to turn it over to back to Bob Harrison.
Thank you so much, Celeste. That was such a compelling presentation. There's a number of questions that are coming in the Q&A box. Please do it in Q&A, by the way, not chat. And we welcome questions as you're hearing issues that come up during the speakers, and we'll return to them at the end. I am seeing them, and we'll ask all of our panelists to respond. Our last speaker is Aquilino Soriana Versosa. Aki has served as executive director of the Filipino Workers Center of Southern California for 20 years, where she's worked in the Filipino community, both in LA and in the Philippines. She's been at the head of see, as part of a growing statewide and national movement of domestic workers. Aki received her bachelor's in Asian American Studies at UCLA, has been the recipient of a Frederick Douglass Abolitionist Award, and is the current board president of the National Domestic Workers Alliance. I have worked with and helped Aki and her organization in Southern California in the spring of this year around several important COVID issues among her leadership and members, and have come to learn more about how this organization has organized on the front lines and been an incredibly effective advocate for a group of, we've heard this term, essential workers and caregivers throughout Southern California. So I really look forward to hearing Aki's presentation and the work of her organization. Aki.
Great, thank you so much. So I will be sharing some pictures, but mostly I'm just going to be talking. And I want to give you a little bit of context. I think, the presentations that came before gave such a great framework, and especially looking at worker centers and other industries, and really understanding the impacts and the problems that are occurring. And I actually just want to give you more of a insight on the caregiving industry, the domestic worker industry, with a focus on caregivers. So home care work and caregiving is actually one of the fastest growing jobs in the United States. I believe according to the statistics, it's poised to be the second fastest growing job in the United States. And this is really because we have this demographic shift where boomers are coming into retirement age, which at this point, there are 10,000 Americans who are turning 65 every day in this country. And 70% of those over the age of 65 will need care on average for 3 years in their lives. And so this means that the need for care is really growing exponentially as well. And that the role of home care workers and other direct care workers is really critical in terms of being able to have allow us as a society to age in our homes and in our communities, where majority of people prefer to age versus being in institutions. So we're absolutely essential workers, one of the fastest growing. And during this pandemic, there have been a lot of impacts, but most of the workers have been needed to continue in their role. So to give you a little bit of an idea of the caregiving industry, some of the characteristics of it. Well, I can give you more of a view of those that we work with, who are the Filipino immigrants who are working in home care. A majority of those that we work with are live-in caregivers who are working in individual homes, but there are also others who are working in small board and care facilities, or residential care facilities for the elders, which are private homes, residential homes turned into small care facilities, usually with about 6 beds. And then also some of them are placed to be the individual home care worker of a resident in a assisted living facility as well. Many of them are experiencing wage theft. So the wages, a very common wage that we see is $5 an hour with no overtime, no meals and rest breaks. And we have actually won overtime for home care workers and nannies here in California, and ended 75 years of exclusion, but we're still in the process of enforcement and really shifting industry standards upwards, so that all workers are receiving the wages that they're due. But it's very rampant across the industry, wage theft. No health care is usually provided. We are included in paid leave, and should be getting paid leave, but as we've been surveying workers, many of them find it very difficult to actually avail of these paid leaves, and especially even in this time of COVID, when they've had to quarantine, most workers have found it very difficult to be paid during that leave. And many of them are working because they're live-in workers. We do see that they struggle and develop kind of long-term chronic diseases. We did a study with Brown University on the impacts of being a live-in worker day after day, and the health impacts that it actually has on the worker, and also their ability to carry on their jobs. And because they are on call 24 hours a day, and really the responsibility, the burden of the person that they're caring for, their health is on them. They're never, when they're live-in and on call, they're never able to get good regenerative sleep. And so it really impacts the quality of sleep, and therefore their long-term and short-term health. And then there's also other hazards. There's a lot of lifting with very minimal equipment usually. And so this is a big industry, but because it's in individual homes, it really is not in the eye of the public, and it's private spaces. So, so it's often not considered an employment site by most people. So when COVID hit, you know, these are workers who are continuing to work and serving some of the most vulnerable in our communities. And they themselves, actually, a majority of the caregivers that we work with are older themselves. So they themselves are also vulnerable populations, but because of the need to survive and the need to work, they have, have to continue to put themselves out there, even though they are themselves seniors. And so when COVID hit, we saw that there was a big need right away for information. Even those who are working in assisted living facilities did not receive good information, or even were included in all of the distribution of PPEs, for example, because they're not direct employees of the facility. And then for those working in the homes, they're outside of a traditional, medical facility or structure. So their access to information about best practices, of course, we were learning a lot, especially early on, was even more confusing and inaccessible for these workers. And families and workers were also just trying to figure it out. So we saw immediately workers who were asked to, even if they were caring for multiple clients, have to drop clients and really just be with one client. We do have workers who are like 24 hours quarantining with their clients. And then others who are trying to, who still have multiple clients and are trying to navigate keeping themselves safe and keeping their clients safe. The pandemic has really shown and exposed the cracks in our society around many different inequalities. And the majority of these workers, are living in crowded housing situations. And when Celeste brought up that quote about they live in, big families all living together, that you know, that's also a part of that necessity in terms of being low wage workers living together and building strong networks to support each other, that should be celebrated, but does put them at a disadvantage during this pandemic. And there were really not a lot of choices that workers had when if they were exposed, or if they were shown, either if they're positive or if they might have been exposed, so had to quarantine during testing. A lot of them did not have safe places where they could, or even just their own rooms where they could quarantine. We had some who had to quarantine in their cars, if they had a car, or tents, or not actually camping, but just on the side of an apartment building next to the trash, or continued to be in crowded housing. We had one house that's 16 caregivers all living together with only 2 bathrooms. And 2 people became positive in this house. And so it became a real crisis for everyone living there. And no one had money to actually move to a hotel or something like that. It also showed cracks around transportation. A majority of our workers travel through public transportation to and from work. So this really forced a lot of the workers to think about whether they would continue to work, make a really hard decision between losing their pay without, and many of them are undocumented, so wouldn't be eligible for unemployment insurance, or the stimulus check and other relief. So making that hard decision of whether they would risk themselves, continue to work and meet their financial needs, or whether they would stop working to try to protect themselves. In the Filipino community, there was a study that was done by USC Professor Adrian De Leon that the LA Times reported on, and it showed that there was a rate of 35% or actually, I'm sorry, so 35% of COVID deaths in Los Angeles. I don't know if I have this right now, but there's a 40% mortality rate in the Filipino community here in Southern California versus the 3.7 mortality rate. And that there was a higher rate of infection also in the Filipino community. And they attributed that to existing illnesses and occupational hazards or occupational exposure, because we do have many who are working in medical fields and who are and other jobs that were required to continue to work, the essential workers. We definitely did experience that and see that we've lost 5 of our members since the beginning of the pandemic, and there are several others that we've lost in the larger community as well. We have been, and so as we're responding and really trying to meet urgent needs, we started doing town hall meetings so that we could get information. We partnered with Dr. Bob Harrison to provide, good information and updated information that are relevant to home care workers through webinar formats. We also started holding general town hall meetings to connect them to other resources. We started getting out care meals, care boxes of groceries, also working with other worker centers to do bulk buys of PPEs to get them out to essential workers in a lot of different fields. We've also, it actually started, we had already been working on this before the pandemic because domestic workers have a lot of hazards on the job already, and we saw especially the extra hazards that domestic workers have during and post the wildfires. So we actually launched a campaign together with the California Domestic Worker Coalition to include domestic workers in Cal OSHA health and safety laws. And then when COVID broke out, or the pandemic broke, is even more relevant and important to include domestic workers. And we are actually on the governor's desk right now, or the bill is on the governor's desk, and we're advocating for him to sign it. On the local level in Los Angeles, we're also really pushing on the county level for public health councils that are made up of workers. Because as Celeste said, workers are those who are on the ground every day, and that they are key stakeholders and partners that can work with the Department of Health to be able to create safer working environments for themselves, but also for consumers. And this public health council is also a way to try and help workers from being retaliated against when they're trying to advocate or implement safer working, safer conditions in the places where they're working during this pandemic. So maybe just share briefly to close out some pictures to give some faces to those that I've been talking about. So these are some of the workers. We do trainings also. Of course, this is pre-pandemic when we've done trainings in person for home care workers who often don't get professional or professional training. Let's see. And then, so this is one of the trainings, and they get to share together best practices. This is a picture of one of the caregivers who was exposed, and while he was waiting for his test results, he lived in a 1-bedroom with 4 other caregivers. So he was forced to put up a tent in the back of his house next to the dumpster to quarantine. Fortunately, we were able to transition him to some emergency sheltering housing just before some of the major rains had hit. We also, this is a picture of some of the caregivers that we connected to testing, especially early on. It was very, very difficult for folks who didn't have, the workers who didn't have health insurance to be able to get tested. These are all workers from one assisted living facility who are hired by an independent, a third-party agency to be clients directly of individual residents there. And as we know, in the facilities, the nursing facilities and assisted living facilities, the rates of positive cases were very high. And in this specific facility, there were many positive cases, some in rooms very close to the ones where these workers were working. And we help to advocate get them testing, get them housing, PPEs, and also to really move the facility to do better contract case tracking, and providing the PPEs to all who were working there, not only the direct employees of the facility. And then we've been gathering donations of masks and doing bulk buys and face shields. And this is some of the workers. This is a worker and her 3 children, as we've been advocating to include domestic workers in the health and safety laws, advocating for SB 1257. And I'm going to stop there so that we can move to the Q&A. I'll pass it back to you.
Thank you so much, Aki, for your presentation and for all the work that you, your members, your leaders do at the PWC. It's amazing work to advocate for and to get better working conditions for the frontline caregivers. There are a number of questions that I'm going to start with. Dr. Benjamin, if I see you're still with us, I'm going to toss this one to you. It was the very first question that we got. And
no problem. You just have to start my video again. There we go.
Okay. A participant asks about the focus on safe reopening, which has been a narrative really almost since, I think, April or May, and how that can ignore the workers who never stopped, who always had to go to work to begin with, and appears to be part of or an overall failure to see racial occupational segregation and the contribution of work to the disproportional burden of COVID on communities of color. And I think that questioner is, I think, linking our discussion today to the focus on racial justice as a larger question. And I think wanted you to comment, or wanted our panel members to comment on that sort of overarching narrative, and I guess maybe ways in which we can articulate our response in the public health and worker health community.
Yeah, this is the result of not having an overarching plan to begin with, and not sitting down and actually thinking through, because what happens when you do a plan is that you get a whole bunch of people into the room, and you begin to, ask yourself questions, and, none of us are going to think of everything. But it requires you to think through in a strategic way from the beginning to the end. So we always understood that we were going to have to, at some point, leave our houses once we went home and sequestered ourselves. And so we didn't really plan for what happened when we went home. That poses the most important question is, okay, who can't do that? Which would have got us to the workers. Secondly, yeah, I think if you just also maybe start my video, I think it's being stopped by the host. So that's the first thing. Then you start thinking, okay, how do we do the testing part of this? And how do we do that effectively? And that's another question, right? We had a lot of early testing when the tests were sparse, but nobody thought about those people that didn't have cars, and remembering that we were trying to test people who were not well. You had to be sick to get a test. Well, 2 buses and 3 block walk isn't conducive with getting a test. And so those kinds of common sense response issues didn't get worked out because they didn't sit down with a piece of paper and first start with the plan that the last administration left them with, but then, expound upon that because we've got something new here. And so planning's everything. And then obviously, once you begin instituting your plan, you're gonna find some things that don't work, but that was a fundamental failure because, as you know, they didn't start thinking about equity until we started yelling.
Just want to echo, I'm sorry, we definitely experienced like the difficulty in getting testing for those who don't drive. The only testing facilities that were open were drive-through, and all of our caregivers did not drive, so it made it very, very difficult.
I just want to add one thing about the testing and the care, and this comes out of reporting from the Texas Observer up in the panhandle of Texas, where there's some really large potato farms. There was some workers who actually one worker died, but other workers had symptoms, and the real problem they had was one, they don't have cars. They are H2A workers. They don't have cars, so they can't get to a clinic. And then if they could arrange through a community member to get to a clinic, the clinics weren't open after their shifts. And then this issue of when you have these workers who live in employer-provided housing, which is, tends to be like mobile homes with many workers living in them. Someone positive, there's no place for them to quarantine. There's not another house where they're quarantining, and there's no access to medical care. So as Dr. Benjamin is saying, like, if they had, had the right people in the room, including workers who could see how this was not going to work, we would have been able to do much better. And I guess I want to be positive. It's not too late for us to fix the situation. We can do this.
Celeste, I think there's a couple of related questions that I think maybe are headed your way. The first is, how have you been able to approach workers and gain the kind of information that you presented to us earlier? The questioner was, I think, really thinking about doing it himself or herself. And, how do you really get that information from the frontline workers, which is so important to be able to relate to policymakers, to advocate on behalf of those workers and work with them. And then, the second in doing that, another participant asked, in terms of messaging about those workers who are affected with illness and deaths, how do you take that and counteract some of the messages about, or to highlight the importance to get that from the workers who you're collaborating with? So the kind of, like, how do you do your work, Celeste? I think our listeners were really impressed with you and kind of wanted to know the secret sauce.
Yeah, so, it didn't happen overnight. I mean, I'm a white person that, grew up in Detroit. So I have, over the years, been invited into spaces where workers are, and have been able to develop relationships with worker centers and try to have been invited to provide information about health and safety, and this is all pre-COVID. And so, I had already had those relationships, and I really take the lead from the workers and what they, want to share. But it really has been a long process for me to be able to develop those relationships, and they're relationships based on trust and respect, and me acknowledging that the workers are the experts, and to the extent that I can provide help or access. So things like, I gave the example of the county health department and, its role with the COVID testing in Bryan, Texas. That was something the workers came to me because they felt, because I have letters after my name, that I would have more success reaching out to the health department and asking those kind of questions. But my advice for individuals who want to develop those relationships, one, I'm happy to have a longer conversation, but two, to recognize that there are amazing organizations in communities. We refer to them, and Aquilina has been involved in this for a long time, worker centers and community organizations, social justice organizations that are right on the ground. And they do want advice and help and expertise from the public health community. And, you know, it's a reciprocal relationship. I mean, I think sometimes the experience has been public, I'll call it like academic researchers, like I want to go in and have a partnership with the Worker Center so I can do a study. And that's probably not going to get you very far. It has to be a very, it has to be a reciprocal relationship. And, but there are great groups out there. And I think that it's not too late to start, you know, making those connections and seeing how with the expertise that you have to make those offers of how to help. And I think some of it is just, it's very, there's so many systems out there, so many different agencies. Some of it is just providing that information, explaining like, how does the system work? Why are there HIPAA rules? Well, how, you know, who's in charge of making decisions? I mean, a lot of it is providing that information so that individuals have a better understanding of how this, you know, how this system works. And then through that process, you can learn their perspective and what they think isn't working. And, you know, I think that that's really important communication that can go on.
And just to say, don't feel bad also, even for worker centers, it takes us a long time to develop these relationships as well. And definitely the partnerships are so valuable. Partnering with Dr. Bob has been so great, as well as others in through UCLA Loesch and others around these different issues. And it's been really critical to help lift up issues that we have and build kind of the legitimacy around it, and just like being able to document things that we know and the things that the workers know are happening, being able to document that and their stories has been really valuable. But then just providing, like you said, Celeste, the information about, you know, access, about how different things work, or information that we just don't have the access to, it is really, really critical. And then we can do so much together with really good partner, like you said, reciprocal and mutually beneficial partnerships. But we're really using, like right now, people see the need to connect with each other during this time. And so we have seen that workers are reaching out, and especially if there's organizations that are providing some assistance, like we're able to provide cash assistance, you know, and other assistance right now. And as we're doing that, we are actually really engaging with workers to understand more holistically about their situations right now and get them activated into our organization. So, so there may be partner organizations that are doing something similar that you could really look for.
There is another question. Actually, there's two more. I'll briefly mention that a questioner or participant was asking about state and local health departments releasing data about workplace outbreaks. And a number of state health departments do post that information. I think Colorado, Michigan, there are several other states that are posting that workplace outbreak data on their websites. In California, the governor just signed a law last week, actually, that as of January is going to require employers to notify the local health department of workplace outbreaks. And the California Department of Public Health will be posting that on our website. And I think that's a valuable source of information that can help shed both, light on what active resources our local and state public health agencies need to devote to frontline workers who are disproportionately impacted, and also track, obviously, the course of this pandemic over time. So I just wanted to mention, I think that's SB 685, if I have the bill correct, and I'll post a link when we send out the information to participants if you want to read more about it. one of our listeners, Michael Foley from Washington State, just posted in the chat that there's been an emergency rule to increase protections for HTA workers in the orchard industry. Massive outbreaks in the Yakima and Wenatchee areas of Washington State among agricultural workers. Michael, I guess I'll ask you if you're still listening to send us or send me the link to that emergency rule that might be helpful for other folks around the country as a model. I wasn't aware of that, Michael, until you just posted that, so thank you. And then finally, another issue has come up, which we really didn't cover in today's webinar, about the tracking of occupational risk in our COVID-19 cases in America, with the collection of industry and occupation data on COVID cases. And the CDC posts those on a national level. A number of states do the same. Unfortunately, the collection of industry and occupational information on our COVID cases is voluntary. So it's not a mandatory field for local health departments who have been in many areas so stretched with the number of positive cases that are coming in every day to keep up with case contact tracing. While I would certainly, among many colleagues on the phone, love to have complete enumeration and ascertainment so we can get accurate data on what workers are infected, where, when, in what workplaces in America, we don't have it. And there have been a number of activities at CSTE. There is a document, which I'll also post for you all, that is excellent guidance to local health departments on how to collect that information, how to code it, how to use it. And the California Department of Public Health has also just updated guidance for employers and local health departments on how to work together to investigate outbreaks, which is something that I think has also been a gap in our local and state epidemiological capacity. So I think there's some excellent information out there that we'll share, but clearly still a lot more to do. I am AB 685. Thank you, Glenn Shore just posted that in the chat box, and I will send a link. So we are nearing the top of the hour. I'm going to give Dr. Benjamin, Aki, and Celeste the right to say one last thing if they'd like for wrap up or any other comments.
Sure, let me just say that we need, as a field, we need to sit down and figure out what our reporting requirements are, because whether it's restaurant information or when you have a Legionella outbreak and whether you have one of these occupational health outbreaks, we really haven't put the evidence and the science together and say, here's who you tell and here's why. It's been kind of a practice issue, but we really need to look behind the evidence, and so we can rationally explain who we tell and who we don't tell and when we tell them. And that's something we need to do pretty soon.
Aki or Celeste, any last comments?
I guess I'd just like to say I really appreciate this conversation, and in thinking about the recovery and how we can actually have this as an opportunity to change things and change the status quo of what it was before, for us to, in the recovery, really center workers and those who are disproportionately impacted as we think about the recovery, so that we come out of this a better society and a stronger, more healthy society than before. And to do that, we have to address head on the issues of inequality.
Thanks, Aki. Celeste, you get the last word.
Along those same lines, what I have heard from from a number of workers. It seems to be the theme is people are so eager to go back to normal. Well, for these workers, normal wasn't that great. So really it's about going beyond COVID. And as Aki said, you know, what type of world and community do we want? And we need to work to create that new reality.
Thanks. So well said. Celeste and Aki and Dr. Benjamin Georges, I really appreciate your participation. And everyone who participated and asked questions were active listeners and engaged in this conversation. So with that, everyone, enjoy the rest of your day and be safe. Thank you.
Thank you.
Thanks, everyone.
Bye.
Thank you.